Dr. Russell Edwards is an ophthalmologist, neuro-ophthalmologist, plastic surgeon from here in San Diego, who's going to talk about clinical manifestations. Do you have movies?
There's a movie embedded, and John tells me that it worked when he loaded it on another PC.
Oh,
we'll
wonderful.
see.
Hope springs eternal. Okay, good.
But it's not a separate file, it's embedded. So I think
all right,
it's gonna
well.
work. If it doesn't, it'll be okay.
Okay, good.
All of the patients know what this video looks like anyway.
All right, fair enough. Okay.
So I want to first thank the BEBRF and Dr. Savino for inviting me to speak, and I want to thank Joanne for including me in the local meetings. It's been a nice learning experience for me to show up to the meetings. And my talk, I think, will not be as complex, and the folks here who have blepharospasm probably won't learn very much because they've been through this. There we go. So blepharospasm is one form of dystonia, and we just heard a lot about dystonia. And just to review again, dystonia is a disorder that's characterized by involuntary muscle movement. For some people, these muscle movements can be painful, but for others, it's not painful, but it's problematic. It's either annoying or it causes a disability. And dystonias can affect virtually any muscle or muscle groups in the body. And most of the time, we don't know the specific cause. We had that one diagram that showed the million causes, and that's probably the most accurate way to understand it. Is there's lots of probable causes. The most common forms of focal dystonias, which are dystonias that affect one muscle or one group of muscles, include cervical dystonia, which will cause either pain or head posturing. People with cervical dystonia may walk around with their head tipped like this all the time, and they can be very uncomfortable, and that can end up causing other problems, headaches and things like that. It's probably the most common focal dystonia. Benign essential, look at the spelling, blepharospasm is a form of focal dystonia. There's also craniofacial dystonias where the other muscles in the face are dystonic. Meige Syndrome, we'll talk about that a little bit more, is a form of dystonia that includes oral or lower face dystonia along with blepharospasm. And then there's a form that's oral mandibular dystonia, which is primarily down in the lower face. There are lots of others, and we heard a little bit about them in Dr. Wu's talk. There's spasmodic dysphonia, where people end up, while they're speaking, finding they can't speak because their ability to form words becomes dystonic. Writer's cramp, I didn't realize that writer's cramp was so specific that you could eat with chopsticks but not write. That's an interesting thing. Musician's dystonia, boy, that would be disabling if you were a professional musician. There are some generalized forms of generalized dystonia that affect many muscles of the body all at once. Multifocal, where you have multiple groups but sort of separate groups that are going into spasm. And hemidystonia, which is more or less one side of the body. Benign essential blepharospasm, that's why we're here. And it's a disorder of progressive involuntary spasms of the eyelid protractors. The protractors are the muscles that affect closure of the eyes, and it results in uncontrolled or poorly controlled eyelid closure. Local eye disorders like dry eye, like iritis, which is an inflammatory eye disorder, or blepharitis, an inflammatory disease of the eyelids, cause irritation to the eye and can cause blinking and probably that's one of the reasons that many patients who have blepharospasm are missed, because these things are common. Blepharospasm is uncommon, and the ophthalmologist, you show up with a little bit of blinking, especially when it's a new problem, and we're all taught common things are common. You look for those and treat those. Blepharospasm is more common in women than in men. I've always wondered if that's true, but in my practice, I'd say that this ratio looks like it holds up about. I haven't actually gone through and done numbers, but it does seem like I have probably 3 times as many women as men. The estimate is about 10 people per 100,000, so it's not very common. And most people who have blepharospasm, benign essential blepharospasm, will have the onset of their disease sometime in their 40s or 50s. There is some familial tendency, don't we know that? But many patients have don't know of any family members who have blepharospasm or other dystonias. So how does it start? It usually starts with an increased blink rate. And it may be asymmetric. When it is asymmetric, many times people will, if they're really sharp and they're thinking this is some kind of a blink problem and not dry eye, may actually diagnose it initially as hemifacial spasm. There's some differences there, and we'll talk about those. But commonly, it's asymmetric at the time of onset, and even when it's affecting both eyes, one eye may be blinking a lot, the other eye may be better controlled. Usually it will progressively get worse over a period of several years, and then it sort of hits bottom, and it sort of stays there for a long time, probably forever. Remission is really uncommon. In fact, in the few patients where I thought I had a patient with blepharospasm, and after several treatments, they come back and they're well, they probably never had benign essential blepharospasm to start with. And they were always atypical patients, too young or something else. As the patients here and their family members know, the diagnosis is commonly delayed. They see doctor after doctor after doctor, and no one knows what it is, or they misdiagnose it. The diagnosis is dry eye. They diagnose it as blepharitis. They say they just don't know. The patients get sent to a psychiatrist. It's very common to be misdiagnosed early on or have a delayed diagnosis. Now, some of that misdiagnosis is probably actually valid. Blepharitis is so common, and if you have a patient who comes in with some blinking and you see a little bit of blepharitis, you're probably going to treat the blepharitis before you say, oh, you have benign essential blepharospasm, we need to treat you with Botox or have surgery or whatever. So some of the delay in diagnosis is perhaps reasonable, but many patients become very disabled before they are diagnosed. So what are the symptoms? In the full-blown form, most patients have forced eyelid closure. There's sometimes spasm in the brow. Sometimes they'll have mid-face spasms. I have at least one patient that I treat, and I sort of used my usual pattern of treatment for blepharospasm, and they would say, oh, when it starts coming back on, when the Botox is wearing off, I feel it right here. So it's sort of down outside of the orbicularis. And treating that gives them relief. Most patients have eyelid sensitivity. Many of them have a gritty sensation in their eyes, and of course that may be part of the reason that they're treated solely for dry eye or blepharitis early on. And after Dr. Wu's talk, we all can sort of realize that the blepharospasm patients may have an abnormal response to what would otherwise be trivial eye irritation, and that may be why what initiates the blepharospasm. Patients with benign essential blepharospasm who are untreated are blind. This uncontrolled blinking renders them unable to do the things that we need to be able to do in our society commonly. They can't drive because you're not safe driving if you can't keep your eyes open while you're at the wheel. You can't even safely cross streets. Stress seems to make it worse. I have lots of patients who, will come in and they say, I'm just doing terrible right now, and I'll ask them questions about what's going on, and a job is lost, or there's a financial condition, or their children or grandchildren are having trouble, and when the stress is relieved, then the treatment seems to be more effective. This is where we're going to find out if it works. Now, how do I select? Do I push this top button to activate something? Oh, I need to use the mouse. So this is just an example of a patient with benign essential blepharospasm. And you can see his eyes are open some, but he's just blinking all the time. And at times, you see he's really got this real forced closure. And he's doing what Dr. Korn mentioned. He's pulling his brows up. You see how he's got all these wrinkles up here. He's elevating his brows to help open his eyes. There may be some apraxia in his, but he's in this little segment of the video. You can see he's able to get his eyes open, but he's blinking a lot. The video actually goes on for about 4 minutes. I didn't include it, and there are times where he's just sitting there and he can't make them open. Meige Syndrome is a special form of blepharitis where there are, in addition to the blepharospasm, they also have an oral mandibular dystonia. So their lips will purse or move, and their chin will pull, and cheeks will pull. And it's sometimes called oral facial dystonia. And we spoke a little bit about apraxia of eyelid opening. Most patients who have an apraxia of eyelid opening are not blepharospasm patients. Patients who have some diseases that we classify as extrapyramidal disorders, particularly something called progressive supranuclear palsy, which is a disease that looks similar to Parkinson's, and many Parkinson's patients have some apraxia of eyelid opening, although they more commonly will have just a delayed or decreased blink. When it is associated with blepharospasm, it's probably not really an apraxia, but rather a focal dystonia of the eyelids, where primarily the pretarsal portion of the orbicularis, and that pretarsal portion is the part of the orbicularis muscle that's closest to your eyelid margins where the lashes are, just a few millimeters above, a few millimeters below, and muscle recordings have demonstrated increased activity in that muscle at the time someone is trying to open their eyes, and that makes it so their eyes won't open easily. And so these patients have, once their eyes have closed, they have trouble opening them on command. They have frequently a reduced blink rate because their eyes close, and then they won't open. Whereas patients who don't have this, who have the more common form of blepharospasm, have an increased blink rate. And when the eyes are open, if it's just apraxia, they don't have obvious orbicularis spasm. They don't seem to have photophobia. And they will commonly have this frontalis muscle. You'll see the arched eyebrows and wrinkles in the forehead from attempting to elevate their eyelids, which we all do when we try to see something. If you want to open your eyes really wide, you elevate your brows. Hemifacial spasm is another problem that I think the BEBRF has some involvement with, although it is not a dystonia. It's not thought to be a dystonia. What happens in this disorder is instead of having this forced blinking and just orbicularis movement, they have contraction of all of the muscles, or most of the muscles, on one side of the face, those muscles that are innervated by the facial nerve. So you see forehead contracture on one side, you see blinking on one side, you see the mouth closing and pursing over to one side, and it's all synchronous. This disorder is thought to be caused by a blood vessel that has sort of gradually repositioned itself, so it's banging against the facial nerve where the facial nerve is exiting the brainstem. And so that banging causes a little bit of damage to the nerve at that point, and that makes the nerve more excitable, and then you get these spasms. The treatment of hemifacial spasm is either using a medication like Botox or some botulinum toxin, or a neurosurgical intervention where the surgeon goes in, finds the facial nerve where it's exiting the brainstem, and puts a little piece of soft material between it and the offending blood vessel. And patients who have the neurosurgical procedure, if and when it works, they do well, and their problem is solved, unless, of course, it recurs for whatever reason. But perhaps 50% of patients who have a neurovascular decompression will have long-term benefit. In the shorter term, that may be higher. So how do we diagnose essential blepharospasm? It's really a clinical diagnosis. There's no blood test, there's no scan that will do it. What we do to diagnose it is we observe how the spasms are, and then we look for things that may be secondary causes of blepharospasm. We look by going through the history. Is there a history of a head injury? Patients who had traumatic brain injury will frequently be more photophobic, and if they're photophobic, they blink. Parkinson's patients, patients who have some schizoaffective disorders. If the patient has a family history of dystonia, then of course we will have there's a more likely chance that a patient who's got blinking will have a blepharospasm. And there are medications associated with dry eye. Many of them are drugs that are used to treat schizophrenic or other schizoaffective disorders. On the examination, we see patients who look like the video I showed you. Intermittent forced eyelid closure. They may have apraxia, so we look for evidence of inability to open the lids. And then, of course, we need to look for local causes of eyelid spasm. Is there evidence of iritis? Is there dry eye? Is there blepharitis? Is there trichiasis? Trichiasis is an eyelash that's turned in. Or is there some other foreign body in the eye? Lab testing is usually not required if the clinical diagnosis is apparent. And imaging with a CAT scan or an MRI is usually not necessary if the clinical exam suggests that this is essential blepharospasm. Treatment is going to be discussed later, but just to review it quickly, botulinum toxins are the mainstay of treatment for benign essential blepharospasm. Some patients do better if they have an orbicularis myectomy, removal of the majority of the orbicularis muscle and the other protractors, the corrugators and procerus muscle. All of the patients who have blepharospasm need to have any of the other associated things treated. If they have signs of dry eye, the dry eye should be treated. If they have signs of blepharitis, the blepharitis should be treated. Remember from Dr. Wu's talk, we know that there's a sort of an upregulation of the blink reflex or a downregulation of inhibition of blink. And so treating things that irritate the eye can make the other treatment, the other treatments that we're giving for blepharitis more effective. Treating blepharitis won't solve the blepharospasm, but it may make control of it better. Treat the light sensitivity with sunglasses, dark glasses. Many people use the blue blocking lenses. I see a few out here with them on. And then there are sensory tricks that people learn, and the doctors out here who treat it ought to at least ask patients about it and then explain to them about it. Like touching, the side of your eye may make it so you can open the eye. Some people will whistle or hum or chew. Some people can find that chewing gum may make it better. So these sensory tricks can help them learn control. Here's just a list of some of them. Lifting a trigger point or touching a trigger point, whistling, singing, humming, playing a musical instrument. All those things are factors that can improve the control. So in conclusion, benign essential blepharospasm is a dystonic order where you have involuntary spasm of the eyelids that result in forced eyelid closure and render patients functionally blind. And it can be associated with other dystonias, and if it's the oral mandibular form, it's called Meige Syndrome. So that's it.